You see the
this level.
you want this level. Okay. So now important thing. First of all, how do you make a diagnosis? Clinical diagnosis. You see, you have neck pain, pain down the arm, and of course not amenable to conservative treatment. Then of course you do the imaging, and then you find, especially MRI, you find there is a prolapse disc between, let's say it is between 3 and 4. Now, important thing is, first of all, identification of the level. Usually you drape the patient, you can stabilize the head, and then drape the patient. And then in this case, we do before we do an incision, under eye control, we select the level and mark the skin where the incision is to be made. And we made a transverse incision, and then we go between the plane, which is lateral or which is medial to the sternocleidomastoid. In that plane where we then dissect it by blunt dissection, and then you go retract the vessels laterally and the esophagus and trachea medially, then you come to the anterior part of this cervical disc. Now even then, you should be careful. You should not just rely on the pre-operative imaging and on your marks. You should identify that this is the proper disc space. But usually what they do, you can either put a needle in the disc that is to be excised and then confirm it with a lateral x-ray. So then you do. Then once you have identified that this is the disc, definitely you have to do an imaging, lateral x-ray, and confirm that this is the disc. Then what you do, you have a knife. So, okay, you use a knife and cut the anterior longitudinal ligament. Once you cut the anterior longitudinal, but before that, what you do is usually you put a distractor. A distractor is something, you see, you put a distractor here. We don't have it here, but you put a distractor in the disc below and the disc above. You put a pin first, and then through the pin, and then these pins coming on either side of the disc. Then you put the distractor. Then you have a special clamp. Then you can distract, and then after distracting, you excise the disc. How do you excise the disc? For clarity, after cutting the annulus, you have either of ronger, and then you take out the disc slowly. So once the disc is taken, and you see at this juncture, you can then also distract further so that the disc is wide. Then you have a small pituitary forceps. I don't have a pituitary forceps. Okay, you have a small pituitary forceps and then take out the disc. Now it's important you take out the disc. You remember your distraction is also there. And then till how much do you take out the disc? Till you see the posterior longitudinal ligament. Now, once you have seen the posterior longitudinal ligament, then it is important from the MRIs to see where the disc is prolapsed. It is usually prolapsed on the lateral side. I usually take out the posterior longitudinal ligament. How do you take out the posterior longitudinal ligament? You can use actually 1 mm Carrison ronger, and slowly you can take out the posterior longitudinal. In this case, you must be extremely careful. Now, before I come to even the posterior longitudinal ligament, after taking off the disc, before I touch the posterior longitudinal ligament, I use a burr and also burr the cartilaginous end plates. You see, you burr these cartilaginous end plates till you find the cortical bone superiorly and inferiorly. And this must be also straight. You can also, don't go, you see you have to burr part of the uncinate process. Don't go lateral to the uncinate process. If you go too laterally, what you get, what is the vessel that is running there? The vertebral arteries are there. So if you go lateral to the uncinate process, you are in danger of injuring the vertebral artery. So you burr and straighten so that you have a nice raw area, but do not take out the cortical bone till you come to the cancellous bone. Then you find there will be collapse of the of your bone, or your, if you are using a cage, there will be a collapse of the cage. So after you have burned or straightened it, then you tackle the posterior longitudinal ligament and then see where the disc has prolapsed. Take out the small prolapse, the disc that has been prolapsed. So once you know there is complete decompression, then the next thing that we have to do is to stabilize the spine. Now, how do you stabilize the spine? You can either take a tricortical bone graft from the iliac crest, you can do that, or nowadays they have come with cages. You see, this is a cage. You find there is a teeth cage, there is a hollow in the center, and in this hollow we can put it a bone graft, either a bone allograft or autograft bone graft. And then how do you judge which size of bone or which size of cage to be put? Usually the instruments, they'll have different sizes of cage. You can go, the smaller size is 6 mm, they are 5, they are 5 mm, and then you put a 5. It is very important that you see at this point your is distracted. So you must see that once you put it is snugly fit, then you release the distraction. And when you release the distraction, if you find that it's too tight, and if you put too long a cage, or if the cage is too big, then what happens? There is separation of the posterior joints. So that is not ideal. You must put the ideal type of cage which is snugly fit, and after you remove the distraction with the distraction pin, then you find that the cage is very stable there. So now in these, previously we do a cortical bone graft, if you put a nice fitting bone cage which is stable, when your distractions are removed, you are happy with this stability, we can just leave it, then put him on a firm hard collar till the bone unites. But nowadays we want them to start moving around early. What we do, we use a cage. In addition to the cage, there's a smaller cage. You use this. You see, once you put this cage with the bone graft, and then you remove it. You remove this. You see, it is quite, you remove the pins, then you find it's quite stable. But to add in more stability, nowadays we use a plate, an anterior cervical plate. So this is, you see, this is a plate. You see, you put a plate in such a way that it spans the disc, and then you must be careful that your size of the plate is adequate. It's not too long, not too short, and then it's ideal that your plate doesn't go to about 5 millimeters towards the adjacent disc. Now, so this is how you put this cage. So select the cage. Usually the instrument vendors will bring different sizes of plate. So once you have left the plate there, initially you use a stabilizing pin. So you stabilize this like that. So you put one pin above and one pin below. Remember, you have already taken out your distractant pin. Now you put this stabilizing pin. So once you have put this pin, what you do, you take an X-ray. You take an X-ray, do an AP, see that the alignment of the plate is in the center, and also lateral to see that the pin is in the vertebral body, not too near to the disc above or disc below. Once you are happy with the pin in the AP and lateral view, then you put your pins. Now, what is the size of pin? Usually the size of the pin comes either 14, 16 or 18 millimeters. And now in your pre-operative MRI or CT scan, you can find out how much it is. These are usually, nowadays we have these pins which are all locking pins. So if it is locking pin, it is not necessary for the pins to have a bicortical purchase. So unicortical purchase is good enough. So you find here, looking at the sizes, usually in a male Asian, we use about 16 millimeter screw. So initially what you do, you use a or to make a hole first with the oar. Then after that, you straight away, I don't think the pin self-tapping. Nowadays, usually previously we have to make a drill. You see, if you have a whole set, you will have to use a drill set to make a hole. And of course, if you have this old set, it is remember that you adjust the drill so that it is not more than 16 millimeters. So the size of the screw that you are using, just use it. Or in fact, I usually use it even less, about 14 millimeters, so that the screw itself will, the next 2 millimeters will find the purchase. So if you have the old set, you just drill it in the direction that is in the bone. So after drilling it, then you can put the screw. But nowadays most of the screws are self-tapping screws. So you put the screws again, first screw below or above, whatever, and diagonally another screw. You see, in this case, you don't need any much help, because you see the